Good morning, everyone. I'm Dr. Tara Kieran. I'm a family doctor at St. Michael's Hospital and the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm delighted to be your moderator today, and I'm glad that our department at University of Toronto has been able to work with the Ontario College of Family Physicians to bring you these sessions every 2 weeks. And so with that, I'm going to turn it over to the president of the OCFP, Dr. Liz Muggah, to give a brief introduction. Liz?
Thanks, Tara. So good morning, everyone. And last session, we hit our 1-year mark. So I am also delighted to be gathering here with you today. So this is our panelists for today. It's going to be an incredible morning. Again, they will introduce themselves in just a minute. And just to remind you that this is MainPro accredited, and you'll get an email about how to register for those credits after this session. And I'll just read the land acknowledgement now. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and the DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. And I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'll hand this back to you, Tara.
As we move towards reconciliation, it's of course part of our job as healthcare professionals is to ensure we have a safe space for our Indigenous patients. And I'm just sharing here a great document that was actually put together for testing and how we can create culturally safe space for Indigenous people when it comes to COVID testing. But I think the principles also apply to vaccination. And in particular, I'm reflecting on this idea of community-based vaccination and community-led vaccination that we've seen being so successful in Northern Ontario, and how that's a route for us to do better for Indigenous people and many of our racialized communities as well. Next slide. As Liz said, this is our 1-year anniversary, and we envision this as a place to bring people together to share and learn. I don't think we realized just how relevant it would be 1 year later. If you've missed past sessions, please do check them out on our website. They are MainPro accredited for even if you attend them asynchronously, so they're a part of a self-learning program. And we build on past sessions as well, so we won't be answering every question on vaccination today. We'll get as many as we can in, but previous sessions have also focused on vaccination, and we urge you to check them out to learn more. Next slide. Thank you to our great planning committee who helps to choose the speakers. If you have any recommendations for the speakers, please do let us know in our evaluation. Next slide. So today I'm of course delighted to introduce our panel. I'm going to turn it over to them one by one so that they can tell you who they are. Next slide. So I'm going to start with Dr. Rosemarie Lall.
Good morning, everyone. Hello from Scarborough. My name is Rosemarie Lall. I practice primary care and am the lead of our FO. I have no conflict of interest, and my financial disclosures are an honorarium from OCFP for this talk and a stipend from the Scarborough Family Medicine site as research lead. Thank you.
Dr. Allison McGeer.
Good morning, everyone. My name is Allison McGeer, and I'm an infectious disease physician at Sinai Health System in Toronto, and formerly the Director of Infection Prevention and Control. You can see that I do a lot of work on adult vaccinations, and I have been on advisory boards and have grant support from many of the companies that are either distributing COVID vaccines now or have COVID vaccines coming in the pipeline.
David? David may be in and out of today's session, so I'm going to go ahead.
I'm here. No,
oh, you're here.
I'm here. Yeah, sorry, everybody. And so I'm going to apologize for keeping my video off. I'm having this session. We're doing another pop-up clinic today with AstraZeneca in a community center, so I'm just on site. So I'm just going to keep my video off. I'm David Kaplan. I'm the Chief of Clinical Quality at Ontario Health, and have some responsibilities there for the primary care file. I receive an honorarium from the Ontario College for these sessions, and employment income from Ontario Health.
Thanks, David. And David, of course, is one of our usual panelists. I'm going to turn it over to Liz.
Hi, so I'm Liz Muggah. I'm a family doctor in Ottawa. I'm also the president of the Ontario College, and I receive a stipend for that role as president. And I will say, David and I usually tag team it pretty heavily on the Q&A. So if we may not be quite as quick if he's also vaccinating. So just your patience appreciated with that for today.
And I'm Tara Kieran, and as a researcher, do have some salary support and grants that I've listed there. And the only one from a commercial company is from Gilead Sciences for a project related to Hep C. Next slide. We, of course, welcome all of you from across the GTA and beyond. It's been great to have so many of you join our sessions regularly. Next slide. You, of course, submitted your questions in advance, and based on your questions, we've designed this session. We're going to really focus on these 5 questions today, as well as try and get as many of the other questions you're submitting addressed as well. We're going to talk about how do we vaccinate efficiently in our clinics, provide what we can, information what we can about the rollout in primary care. And then Dr. McGeer is going to talk about some of the latest guidance and evidence around AstraZeneca. We've got lots of questions in the past around that 16-week dosing interval. I know people are concerned about that, so we're going to address that again. And you know, the new variants of concern, as well as I know many of your questions. Next slide. So I see that many of you guys are recurrent attendees, so we've already got lots of questions in the Q&A box, which is great. So that is where we like you to put your questions. Please type them into the Q&A box, not into the chat. We will prioritize the questions in the Q&A box that get the most thumbs up. So if you like a question, please, before you submit your own, look at the questions that are there. If there's one that's similar to yours, put a thumbs up. The ones that go to the top with a thumbs up are the ones that we will prioritize answering. Please also do, if you have time, read through the answers. I will try and note some of the more common things verbally so that everyone can hear that. If you have some things that you want to share with others, resources, comments, those are wonderful to put into the chat. And so love for you to use the chat as a place to connect with others. But please put your questions in the Q&A. Next slide. So just as we begin, I think Liz and I just wanted to, address how everyone in attending today must be feeling. This has been an incredibly difficult couple of weeks, on top of an incredibly difficult year. And I think for so many of us, seeing these numbers of cases rise, and in particular the number of hospitalizations and ICU admissions and deaths rise, has been morally distressing, knowing that we could have done so much to prevent where we are today. And so many of us are working so hard. And to see this happening despite our hard work, I think is particularly morally injurious. We're supporting our patients, we're supporting our families. And I guess we wanted to acknowledge that, and I guess acknowledge also the great things that you guys are doing to help make this better. Next slide. I will say for myself, I have struggled with what's been happening, and like many healthcare providers, I have tried to give voice and advocate, and many of you have probably seen this letter that was posted, open letter and healthy debate. There's also a great campaign called Health Workers Fight Back, and I myself called Doug Ford this week just to express what I thought needed to happen, and it felt like something important to do that was in keeping with our democratic society. Next slide. And of course, all of us have really key roles to play within primary care. And so I hope many of you saw this guidance that the OCFP put together and that Liz sent out in their newsletter. I know you're focusing on caring for the people in your practice and for caring for people with COVID, working in a testing assessment center, supporting people who are at home with COVID, and then of course through vaccination, which is what we're going to talk about more today. With that, I'm just going to turn it over to Liz for just a couple of remarks.
Yeah, so thanks, Tara. I think, as you said, I think we really felt it was important to acknowledge personally, how each of us have been feeling. So as a leader, this has not been an easy time. It's been frustrating to be dealing with a system and a government that doesn't always listen to what healthcare leaders and our scientists have to say. And I would say Friday was really tough in terms of just evidence of that. I think what's really important right now, though, is to not fall into a place of despair or cynicism. And I wanted to talk a bit about hope, not, the pie in the sky or naive hope, but hope that's really grounded in the facts and in the truth, because I actually think that kind of hope is really the place that allows us the moral authority to act. And hope sits where we are now, in between the situation that we have and where we want to be. And it's in this place of uncertainty, and there's no profession that is better at dealing with uncertainty than family doctors. And we have really stepped into that place. And I would say, when we think about hope as a call and a platform for action, a couple of things for me come to mind. And one of them really is around the service that you're giving, the action every day that you give to your patients in so many ways, and what a difference that is making truly as the backbone of keeping this province well and healthy, and now stepping up again as our hospitals become overburdened. So just your clinical service. And we're going to hear more about that from Rosemarie, who is such a tremendous leader in Scarborough, which has been so hard hit. And I would say the activism is hugely important. Never before, really, I think, have we seen the need for civic leadership, for clinical leadership, and it makes a difference. I want to say just how incredibly proud I am of the family physician voices that are everywhere across the province calling for what we know is right for our patients. I'm not saying we all have to be, activists, but I think by a revolutionary activist, so to say, but I think by stepping up and speaking out, it's so important. I think Allison actually today is a brave leader in that regard. She, in terms of speaking out and giving us the truth. So I'm looking forward to her comments today. And finally, to connection, which is another action we can take. And just, I see connection as such a fertilizer for our hope. And I take these sessions for me as an opportunity to connect with all of you. I bring them with me. I bring your voices with me all the time at all the tables that I sit in, and how powerful this is as an antidote to what we're feeling. So with that, I'll close and just thank you feel today very strongly that these community of practices are just an example of the way that we can bring evidence and action and our clinical work together in a connected community, and how powerful that is.
Thank you, Liz. I think many in the chat are just reflecting on what you're saying, and thanking you for addressing this head on. So I'm going to, with that, hope in mind, turn it over to Rosemarie Lall, because I think she's been doing incredible work in Scarborough, trying to bring vaccines to her patients, and I look forward to all of us learning from her. Rosemarie?
Okay, next slide, please. So a little bit of background. First of all, thank you so much for inviting me to share our experience at our clinic in setting up the COVID vaccination center. So our background, and to put it in context, we are a FO, 8 physicians located at Markham and Eglinton, which is otherwise known as Scarborough Village. That is one of the hard hit postal codes. Our EMR is Oscar, and we are administering only AstraZeneca, currently now in the 40+ range. We started at 60 and then 55, and as it dropped down, so we increase our range. Just to let you know, the vaccination clinic are by appointment only, and they're made by emails or telephone calls. And technology that we're using primarily are just the desktop computers. Next slide, please. So with respect to timing and resources, the vaccination clinics we feel should be held outside of clinic hours, so outside of in-person clinic hours. And so, for example, on a Saturday, we'll hold them at 1 o'clock and they'll go till 2 o'clock or 3 o'clock, depending on the numbers. And on the weekdays, we will hold them after physicians finish seeing patients in clinic, which is at 4 p.m. Staffing usually consists of 3 roles. That's how we broke it down. We have 2 to 3 runners, and they're in charge of screening at the entrance, managing patient flow, preparing the rooms, and some other things that I will talk about. We have 2 to 3 administrators, and they're the ones who enter everything in COVAX, register patients, and provide receipts, and bill also the visits. And then we have the 1 vaccinator who's the physician. Next slide, please. So I decided to show you some photos just because photos interest me more than writing. And I wanted to explain how we did this. So in photo 1, the patient is scheduled via email or telephone call. We put them in our EMR register, our own personal EMR register. And the staff email the consent form and the aftercare sheet with the instruction to the patient that they should fill in the consent form, print it out, and bring it to the appointment. In the middle photo, 1 hour before the start of the clinic, we use SQL as a query to upload all of the relevant information in the EMR scheduler, and we format it in a way that COVAX will accept it. And then it is mass uploaded into COVAX. This is probably the most critical piece to the smooth running of a clinic. And yesterday we had a clinic in COVAX, didn't allow us to upload until 5 minutes into the clinic, and it was a bit hairy, but it did work out. The other thing that we do too is we pre-print the receipts. And in the last slide, the last photo here, at check-in, the patient is checked in, registered, the consent is reviewed by the administrative staff. The receipt in the back, which are all pre-printed, arranged alphabetically, is handed to the patient, and then the patient is handed off to the runner who puts the patient in the room. The vaccination is billed right away. Next slide, please. With respect to clinic flow, I tried to break this down with the roles. So what the runner does, and as you can see in this photo, this is how the runner sets up all of our vaccinations. So everything is put out there. The runner's responsibilities are putting the patient safely in the appropriate flow into the room, cleaning the room between patients. Once the patient is in the room, we ask the patient to get your arm ready and make sure that your consent is accessible to the vaccinator. Once the patient leaves the room, then the consents will be collected and run up to the administrators to start entering into COVAX. And the runner also keeps an eye on any post-vaccination issues. The number 2 or middle is what the vaccinator does. The vaccinator comes in, says hello, checks a consent, and we've condensed everything into a 1-pager, so it's very easy to see. Administers the vaccination, writes down the time, and we, as a tip, move our clocks 15 minutes ahead, so it's really easy to see what 15 minutes is. And then the patient stays in the room. They don't move anywhere. They stay there for 15 minutes. Vaccinator leaves, puts the consent on the outside of the room, and in our case, we have wire baskets, and as the runner runs around to the various places, she can pick up the consents. And then the vaccinator moves on to the next patient, and that process takes about 60 seconds to 90 seconds. And then this third photo is just a reminder of the important role of our admin staff, and they continuously enter into COVAX. Next slide, please. So I also wanted to show you a sense of how our clinic is set up. And so on photo 1, this is one of our runners who stands outside, directs traffic, makes sure that we have safe distancing. I wanted to draw your attention to the fluorescent duct tape that we have there. And she directs them into the entrance. At the table, you can't really see, oh, actually on slide 2, we have a large bottle of sanitizer, and she reminds them to sanitize their hands. At the far end, I don't think if you can see it, that is our exit door. So we have a 1-way flow of patients. Third picture shows you the registration desk with our little runner figure all the way in the back. And so once you get registered, the patient gets sent to the runner. And in the corridor here, we have 12 rooms in our office, and this is our next runner. Next slide, please. Just to let you know, here's our pre-printed receipts arranged alphabetically in piles, which are handed to the patient before they go off to the room. Next slide, please. What I wanted to show you here was just an example of the one-page consent. So what we decided to do is take the several pages that the ministry has, condense it into one page. The vaccinator can look at it quickly and identify yeses and nos and ask the questions. The middle page is also what's emailed out, and that is your aftercare. And this last far right is what our receipt looks like. So this is your receipt of your vaccination. It's put in as an e-form in OSCAR, if people are familiar with OSCAR. We hand them this piece of paper, but also when we enter in COVAX, we email them as well. So we try to collect as many emails as possible. Next slide, please. So what worked really well? Okay, I would have to say that the most important thing is that we have to use our technology. So inviting people by email, so low-hanging fruit, we go through our EMR and see who fits the age categories. Sending everything through email for consent, aftercare, receipts being printed in advance, very easy. Uploading through SQL and working within our space. So we happen to have, I think, about 22 spaces that we can safely seat people at. But that's not to say that if you have a smaller office, you can't make it work. I think you have to look at your space, take all of these good learnings from many other physicians who have given talks similar to this and see how you're going to adapt it. Because at the end of the day, we need to have this working in our offices. So challenges and barriers. Initially, when I started, COVAX was, I found, a real barrier, and we wanted to find efficiencies and workarounds, and I think we did. The other thing that I would urge COVAX on to do is allow us to upload more information. We cannot upload the family physician. So we have the administrators have to manually enter that. And then the last piece, which is changing, is AstraZeneca uptake is weak. There's a lot of hesitancy around it. But that being said, we are actually having good numbers in our area. And so we constantly are ordering more AstraZeneca. It's not impossible. This is really something that we can do. And so next slide, please, Brian. Successes. Well, we've now got our vaccinators up to 40 to 45 doses per hour. Running the clinics do not have to interfere with your daily work, but should you wish to have it as part of your daily work while you're on the phone, there are ways of figuring that out. Within 15 minutes or so after the vaccination clinic is finished, all of the data is entered into COVAX. Billings are complete. Patients are incredibly happy. I was telling someone, I really want to have balloons every time we run a clinic, and that's unfortunately not possible. They're thankful, vaccinators are happy, it's win-win. And I just want to tell you all, this can be done in a physician's office. You really have to be confident of it and find workarounds. And that's it. Thank you so much for your time. Please, there's my email. I welcome any questions or chats offline. Thanks so much.
Thanks so much, Rosemarie, and thanks for encouraging us that this really can be done at family doctors' offices. We know from past sessions that the majority of doctors that have attended our community of practice were interested in doing this, and I know many have been doing it. Liz, I wonder if I can turn it over to you to give us a little bit of an update on, if people want to do this, how can they be involved? And if they are doing it, how are we going to be getting more vaccine to primary care and when?
Yeah. Thanks, Tara, and thanks, Rosemarie. Yeah, it's just such a great story and such tremendous leadership, and so important in Scarborough, given what you're facing. So As people probably know, this latest allotment, AstraZeneca was around 584,000 doses, and of that, 120,000 went to these primary care practices across all 34 public health units, somewhere around 300. Believe it or not, we do not have the exact list of who is and isn't participating. That's something that ministry has, but the up-to-date list we don't have. But we do understand that all 34 public health units leaned in and really tried to identify practices. So of that 120,000 doses, that what we heard this week is about 30% of that has now gotten into the arms of patients. So that's great. And we're seeing that number continue to increase. So, I think the stories you've heard in this community of practice certainly have suggested that it takes a little while to get things going. It takes a lot of work, so time and work, but we're seeing people ramping up and giving those vaccines. And I have no doubt we'll get through that 120,000. Certainly Rosemarie's experience is similar to what we had in our practice, that once the age dropped, we saw a huge uptick. And so lots of difference across all the public health units. So not just with each public health unit, but I think within each region and even within a same community about how each experience has been with these different practices. So that's just the reality. I would really encourage people who want to be involved to continue to reach out to the primary care lead or their public health unit, medical officer of health about your interest in participating. I think this is really important. The vaccines are going to keep coming. We know that mass vaccination and pharmacy on their own are not going to hit all the patients. If you are able to step up and want to do this in your office, please let them know. And maybe Mina can share, we've previously shared that list of who the primary care leads are and the public health, each of the public health units. She can put that in the chat. A major issue is going to be supply. So obviously things have started to, it's just never clear exactly how much supply we're going to get. We've had additional bumps because some of our AstraZeneca was coming from India. And that, of course, with the, terrible situation in India, we're not going to be getting that AstraZeneca. So, we're going to get some from the UK, but now it looks like that might also be delayed. There is Moderna that, theoretically could come into our offices, and we've seen some areas like Lambton and Kingston and others offering Moderna, but that vaccine is now somewhere up in the air as well. I think the Pfizer is probably going to be the most reliable supply. I don't have a date for when that's going to come. I think we're expecting somewhere around 1 million doses to Canada next week, and that might continue. I presume the federal government is scrambling to try to find Pfizer from wherever else they can. That will be a challenge, but not impossible in primary care. So, I think for us, what we would hope for is that the AstraZeneca increases, and that the J&J, which I think is supposed to come in early May, which will also be good for our offices, that continues to be made available. So I would say, please step up and put yourself forward if you're interested. We can also help share with you others in your area who are vaccinating. If you just want to hear more, have a one-to-one conversation with a clinic who's doing this. So just reach out to the OCFP. We can help with that, or join the Ontario Health Quorum. They've got a community of practice just for people who are vaccinating right now. So you can also join that, and David has that information, and maybe Mina can put that in the chat too. So maybe I'll just stop there.
Thanks, Liz.
Mm-hmm.
Yeah, so some great discussion in the chat. Others talking about the successful clinics they've run, and a couple of family health teams, and I think Jennifer Young and Collingwood saying a great drive-through model. So great to see this happening and people making those connections. I think some people are also, Mina's put into the chat where you can find your public health unit contact. So that's really important. So Rosemarie, there were, I think, a few questions for you, and maybe you could just address a couple of these. I think somebody made the comment that, this is possible in a large office, but maybe not in a small office. Another person made a comment that, a FO is more well-funded than a FIG. And so, maybe it's not possible in a FIG. And then another person asked about the billing code. So I wonder if you could address some of these issues, Rosemarie.
So with respect to a small office, the way I've thought it out is look at your waiting space. And if you are able to space patients out and put them in their seats and let them stay there. And we have, yes, I do agree. We are a larger office, and in our 2 waiting rooms, we have a total of 10 seats. And so we actually vaccinate in the waiting room. Patients don't seem to mind it. They don't seem to have any privacy issues with showing their arm. In a small space, it depends on how many rooms you have. You can also maybe think about partnering with the physician next door if your office is set up. And I can actually think in my head how to configure it. I would really encourage anyone to reach out to me. Between my office manager and myself, we can help you make it work. I really need to see your space, but I am convinced that it is feasible. With respect to billing, if you kind of do the math, 45, so for example, yesterday we had 100 patients vaccinated in 2.5 hours. So in 2.5 hours, the physician vaccinated times 18.6, because we do fee for service for that. Vaccinators really happy. And even after they pay an overhead, which helps pay for the staffing, I think that works out well. But with this model, you need to be able to get as many vaccines in arm per hour. The other thing that I forgot to mention is that I don't bring on extra staff. During COVID, we decided not to let go of any of our staff. So we already staffed with that number of people, and we've just redeployed them to do different things. So I think it actually is feasible. We use what we have. With respect to extra funding, I'm a capitation. That's all we have. We're not a FIT. I'm not affiliated with a FIT. I don't have any I don't have nurses. My triage staff are actually people that are lab techs that are trained. With respect to drawing up the needles, and again, this is a really short talk, so I didn't get into all of that. I've taught my triage staff how to draw up a needle. It's pretty simple. They're pre-drawn before. We don't do the full amount. So yesterday we drew up 80 in anticipation there might be some drop-offs. Was there another question, Tara?
I think that that was great. I think somebody asked how many how many rooms you had. Was it 12 or 22?
So we have 12 rooms, and then in our 2 waiting rooms, we've identified a total of 10 extra spots. So it's really a circuit. We put one person in the room and you keep on going in the circle. So if you do the math, 22 spaces, by the time you start in room 1 and finish space number 22, the person in room 1 has done their 15 minutes waiting time and they can leave. And really, so if the physician just does a circuit round and round and round, there's really no waiting. For 100 people yesterday, example, just because it's in my head, I think we had one person waiting while the other patient was registering in front of them. It's very efficient, but again, there are many configurations, and I really encourage anyone just to reach out to me, and I'm happy to help them sort this out.
We actually have 477 doses. No.
And so I think that Dr. Lam asked, how do you deal with pre-printed receipts if there are no-shows? Does COVAX allow you to cancel the vaccination that's been recorded?
Yep, they're not entered into COVAX. They are entered into our EMR, and we've done an e-form in which we just print it. So they're just destroyed at the end of the day. And this actually helps us to reconcile who's no-show and who shows up, because at the end of the day, all of the no-shows that we haven't billed should equal the number of printed receipts that have not been picked up. But the official receipt is actually given once the information is entered into COVAX. That's just how we figured it would be easier. Patient walks out with a piece of paper. And remember, not everyone has an email address. So they at least have a piece of paper to show that they've been given their vaccination. And again, we're on OSCAR, but I'm sure all the other EMRs have that facility to pre-populate something.
Yeah, I'd only add, Rosemary's clinic is still emailing the official Ontario receipt to patients.
Absolutely, David. Thank you for clarifying. Yeah.
And I think you're doing paper registration and consenting for those who can't pre-register by email, which I saw in the chat. And then, so many people are exchanging contact information and tips in the chat, which is great. So Jordana Sachs, for example, is saying that they have community pharmacist volunteers drop their needles, and she's also offered for them to help Others are just you know, some people are requesting help, some people are providing their contact. So we're going to take down a bunch of that contact and try and connect people afterwards. So thank you, Rosemarie, for providing such a practical guide to what you do. And to the previous comment about, you know, can this be done in a FIG setting? We did have a previous panelist speak just to that. So Dr. Sohal Gupta, I believe, spoke to that, and that was, I think, 2 weeks ago, although time moves very quickly. So maybe, oh, it was 4 weeks ago, 4 weeks ago. So it's in the past session, and we'll figure that out to send. We'll put the past session link on the chat as well, so that you can review that. And he did say it was, you know, from a financial perspective, remunerative. So I'm going to turn it now to Dr. McGeer to give us some remarks. Dr. McGeer has been like really busy in the Q&A answering a lot of questions. So, but I'm also going to get her to answer some of those popular ones live, so don't fret. And I know in her own the talk she's presented, she'll be getting to many of the things that you've been asking about. So, Allison, I'll turn it over to you.
Thanks very much, Tara, and thanks to all of you. I think you know, this is a pandemic, and everything is chaos. But amongst the chaos, there are many miracles. And one of my miracles has been the primary care response, and the passion and the organization and the ability of our primary care physicians to respond, particularly to ramping up vaccination clinics. No question, it's been extraordinarily difficult and complicated. But if you just pause for a moment and think about the fact that we have delivered impossible to deliver vaccines, that we don't know when we're getting them, to 30% of the adult population in Ontario, that's a miracle, okay? So just every once in a while, you just need to stop and say, there are really good things going on, and we're gonna get through this. And so I wanna start on this slide with the next good news of the week, which is that despite such a horrible week last week, cases in Ontario look like they're plateauing. So we may be thoroughly messing up public health intervention communication, but as Ontarians, we're obviously responding. Okay, the fact that it would be nice if our cases were going down, and they're not going down yet, but they're not going up. And the fact that they're not going up is also a miracle. Okay, it's not what I thought was going to happen this week, given everything that's been going on. So I'm really hoping that this is the turning point, that we have flattened it, and that people are going to continue to respond, and we will see cases start to decline. So that's the good news. Now let's go on to other stuff. Next slide, please. Okay, so a few new things this week. The Janssen study is out in the New England Journal, looking at its efficacy against dose 1 globally, okay, after 1 dose, and vaccine efficacy of 66% versus moderate disease. Janssen has these really stupid and complicated definitions of moderate and severe disease. I don't know how they developed them. I can't even remember them. There's this complex thing about how many symptoms you have to have. So moderate disease is not what you and I would think of as moderate disease, but doesn't matter. The effect is 66% against moderate or severe disease, and 85% against severe critical disease, which is generally speaking oxygen requirement or ICU requirement. And a significant fraction of their enrollment was in South Africa, and their vaccine efficacy is 64% and 82% against moderate and severe disease. And that's, of course, almost all B351. So that's another little check mark of a vaccine similar to the other vaccines we have that looks like it's working against the South African variant, which is really good news. Okay, one more little brick in the wall of what we know about efficacy against variants. Also this week in the New England Journal, first publication from the Americans about vaccine safety in pregnancy. So this comes from the US vSafe program, which is a text-based application for recording adverse events after vaccination that the CDC is running, and the US vaccine adverse event reporting system. They've had 35,691 vaccinations during pregnancy reported in vSafe, and they've got nearly 4,000 of them in a registry with detailed follow-up. And they looked at all their VAERS reporting data. And the short version of it is there are no safety signals that anybody has seen. Obviously, this is just observational, and congenital abnormalities occur and pregnancy losses occur. So all you can say is that so far, all of them are within the completely normal range. There's nothing about the congenital anomalies that looks like it's anything. Clearly, we need more and ongoing data, but so far, it all looks just fine. And on a small note, just because I care about transmission, a nice article from the CDC and JAMA Internal Medicine demonstrating that even in people, NBA players who persistently tested positive after they were out of isolation, no documented transmission at all. So what we've kind of figured out already, but nice to have documentation. Next slide. Okay. Now, the vaccine adverse event of the week, I think we've settled on calling it VIT, which is vaccine-induced thrombotic thrombocytopenia. And this is the good resources about this, from my perspective, are what the link that's on the bottom of the slide, which is an ASH seminar that you can watch, American Society for Hematology seminar that you can watch, or you can download the slides. The Ontario Science Table document on VIT is also pretty good for an introduction. It appears that this is similar to heparin-induced thrombotic thrombocytopenia. So something in the viral vectored vaccines, not just AZ, it happens with the J&J vaccine as well. So there's some anionic component that binds to platelet factor 4, and that combination then gets bound by these heparin binding antibodies, and that activates platelets. And when you activate the platelets, two things happen. They trigger thrombosis, but they also get consumed, removed by the spleen. This is Allison's attempt at simple explanation of this. The truth is it's complicated, and nobody really understands how it works. But what is clear is that whatever is happening with these vaccines, it's something that replicates what you get with heparin-induced antibodies and what happens to some people after surgery, even in the absence of heparin, okay? The reason that's important is because the treatment for it is very different from the treatment for usual thrombocytopenia. You need to be alert to it, and you don't want to give platelet transfusions to people who are thrombocytopenic. They need to be on oral anticoagulants. It remains a bit of a challenge to diagnose. There are algorithms for diagnosis, but it's still difficult. And you really need a hematology referral to figure out what's going on. Next slide. So now the question becomes, okay, if we've established, and I don't think there's any question now, that vaccine-induced thrombotic thrombocytopenia is a rare but non-zero complication of viral vectored vaccines, how do we respond by recommending vaccines? And the challenge here is about thinking about the balance between the risk of COVID to any individual and the risk of an AstraZeneca vaccine. If we weren't short of vaccines, if we had enough mRNA vaccines, then everybody would get an mRNA vaccine, because there's no question that at a really low risk level, that they are safer. So I think these viral vector vaccines, unless we can solve the problem, are gone in the long term. But in the short term, when we don't have enough vaccines and the threat of COVID is significant and real, we need to get people protected against COVID. And this is one of the calculations of what the balance of risks is for the current AZ vaccine in current states of COVID. comes from a UK group, and they have a series of algorithms looking at low risk, medium risk, and high risk of COVID. And I've chosen the low risk for this because of all the uncertainties involved. So this risk of 2 per 10,000 cases per day is actually about half of the current risk in Ontario. So these numbers would get larger on the blue side. At the same time, the risk that they chose for vaccine-induced thrombotic thrombocytopenia is, in my view, a bit low. And we're now, you can see that when they did this calculation a couple of weeks ago, they assumed that the risk was higher in younger people, and that's probably not true now. Looking at the evolving data, it really looks like it's even over the age groups, and our original assumptions were because the European countries that saw this first were primarily vaccinating young healthcare workers, and so we saw it in younger women, but that's just an effect of who was being vaccinated as opposed to what's actually happening with this complication. Nonetheless, what you can see here is that why Ontario has gone with a 40+ group at the moment, looking at the balance, you are safer to get an AstraZeneca COVID vaccine than to wait for Pfizer if you're over 40 in Ontario. There's continuously evolving data on this. So there's supposed to be a new NACI statement out. It's been delayed a number of times, I think, because people are arguing about the content and the model. This is really difficult because there are, I think it's on the next slide. Go one more slide. Yeah. There are a bunch of uncertainties about this that make it really hard to do the modeling. So the estimated risk of VIT post-vaccine goes anywhere from 1 in 25,000 to 1 in a million. So that makes it really hard to estimate. Projecting what the future COVID incidence is in Ontario, not that easy, right? But it matters. What the impact of vaccine is on the transmission of disease. If I'm caring for my 96-year-old mother and I don't want to give it to her, should I get the AstraZeneca vaccine or wait? You know, so transmission matters. And of course, it also depends on what our vaccine distribution success is, because that alters future rate of COVID. So the NACI statement was supposed to come out again yesterday and didn't. I'm thinking maybe now next week. And in the US, the Advisory Committee on Immunization Practices is having another meeting today to talk about the J&J vaccine and what they think about using the J&J vaccine in the States. So we're going to continue to see information coming out, but I think we've all agreed that at the moment in Ontario, AstraZeneca vaccine is a good choice for people 40 and over. Next slide. Okay, now the big question, right? Is a single dose enough, and where's it going to get us? And to me, the important evidence about how we're doing with single doses is about looking at the individual and population impact of disease. So the first evidence that a single dose is enough is that in long-term care facilities in Quebec and British Columbia and the UK, people got a single dose of vaccine. And there is no or nearly no disease in long-term care in Quebec and BC. And if you just click down once, this is a graph of what happened in Ontario long-term care facilities to the daily risk of COVID in those facilities. And the reason I'm putting this up is partly because I don't have data from Quebec and BC to show you. I just have what people are telling me, but also to show you that by 21 days after the first dose of Pfizer vaccine in each of these facilities, the risk of getting COVID had gone down by 70%. So in our frailest, most vulnerable, least likely to respond to vaccine population, a single dose of vaccine was enormously successful in reducing disease in the short term. So that's piece of evidence one. Second piece of evidence is what's happening in the UK. The UK has taken the Canadian approach of let's get a single dose into everybody as quickly as we can and then catch up with the second doses. Click one more down. And here's case rates in the United Kingdom. If we were where the United Kingdom is now, we'd be having 500 cases of COVID a day in Ontario. Imagine how nice that would be, just for a moment, okay? We're gonna get there, okay? But we're not there yet. And so the UK peaked at 60,000 cases a day at the beginning of January. They went into hard lockdown. Admittedly, they closed schools. They had stay-at-home orders. They're now at about 50% of their population vaccinated with a single dose, and they've started to lift the restrictions. Now, it's still early, okay? They started at the end of March. We're only 3 weeks into April, but they have not seen a significant increase yet. And so we'll be watching them very carefully over the next few weeks because they're ahead of us. And as long as their numbers hold, as they continue to release restrictions, we'll know that the single dose vaccine approach is working. And then the next question is, so do we know anything about whether single doses reduce transmission? And there's data from two sources for that. The first of them is a reduction in the UK, again, in routine testing of healthcare workers, where post first dose of vaccine, you can see that the proportion of asymptomatic healthcare workers screens has gone down. And the second piece of evidence is an admin database study in the UK looking at the risk to household contacts of vaccinated healthcare workers. So this has nothing to do with being healthcare workers. This study just asked the question, if you have a household contact who is vaccinated, does that reduce your risk of getting COVID? It's obviously not going to reduce it completely because you can still get it from your workplace or anywhere else in the community. But you can see that it does reduce it significantly. This just shows you income quintiles because it was easy to cut and paste out of the article. But you can see overall that there's about a 35% reduction in disease in the household contacts of healthcare workers who've had a first dose of vaccine compared to healthcare workers who had not yet been vaccinated. So we do know that first doses reduce transmission. None of this tells us what happens 4 or 5 months after the first dose. It's an evolving situation we need to be watching. I think we're all hoping that we'll get to the second dose before the 4 months are up. But at the moment, the strategy of single dose into as many arms as possible really does look like the best approach for control of COVID until we have enough vaccine. Next slide. Okay, and then just to look at how we're doing with vaccines, this is actually a CTV vaccine tracker, so you can watch vaccines going up in Canada. You can see that in both Canada and Ontario, we're at about 32% of our adult population vaccinated. Again, this is a miracle. We're going up by 1% a day. So in 19 days, we'll be where the UK is now, which is 50% of the population of adults with 1 dose. And that really, you know, this is what gives me hope. The fact that we appear to have flattened the curve this week in Ontario, the fact that we're getting vaccine to 1% of our population a day, the fact that our Pfizer supply is going to double starting not next week, but the week after. So we're currently getting about 400,000 doses of Pfizer. It's going up to just under 800,000 doses a week in 10 days. So even with Moderna and AstraZeneca being a little bit uncertain, we can still maintain greater than 1% a day for that period of time. And so I'm feeling a lot better at the end of this week than I was at the end of last week. I really do think that we are making progress and that things are going to be much better about 3 weeks from now. Still really difficult in our ICUs, no question, for probably at least 8 or 10 weeks, but much better in the community and in terms of numbers of cases a day. Thank you.
Thanks so much, Allison. That was a great tour de force, and I really appreciate that hope that you left us with right there at the end. I'm going to go to a couple of questions. I think these are a couple of questions you actually answered in the Q&A, but I think they're worth expanding on, and they were very popular questions. So the first is just, they're both related to variants. So one is about, can you tell us more about the Indian double variant? And then the second is about the effectiveness of AstraZeneca and the different variants.
Yeah. So there's a lot we don't know about the Indian variant at the moment. And it's also an illustration of, if you think about it, the UK variant appeared in any numbers at the beginning of September in a corner of the United Kingdom, was recognized in November. It took us until February, maybe March even, to get data on comparative severity and comparative transmissibility. So these are really hard data to put together. And it's going to be, there's just no way past, this is going to be an ongoing frustration as we try to look at variants that and that's in the UK. The UK has, I think, unquestionably the best organization for getting data about what's going on in this pandemic relative to other countries. So, so figuring out what's happening with variants is going to be hard. The reason people are worried about the Indian variant is because the number of cases in India is skyrocketing. And that's what you expect to see if you have the appearance of a new variant. And it looks like that might be in association with this new variant. Variant has an E484K mutation, so it's that 484 site that sits in the fold, and presumably affects the virus's ability to bind to epithelial cells. And it's got another mutation that may be associated with reduced immunogenicity, which causes people to worry. But that's the sum total of what I know about this variant. And so we don't know whether the increase in cases are because of this variant or something else. We don't know whether there's really reduced immunogenicity. We don't know what's going to happen. We do know, and this is going to be one of the big challenges going forward. We do know that the spread of variants is really affected by travel, right? This is not what we believed before this pandemic about viruses in general, because the travel restrictions don't work for flu, but they do work to protect countries from the introduction of variants of coronavirus. And that's meant that the EU and the UK have stopped travel to the Indian subcontinent because they're worried about this variant. And so we're going to be stuck in this really difficult position where we definitely don't want variants, okay, that have reduced response to vaccines or that are more transmissible, but we also don't want to be interfering with travel. And trying to run that line of protection of the population, but maintenance of our relationship with the world, is going to be really difficult for the next few months. And then vaccine effectiveness against variants. Yeah, patience is a virtue, even if it's not one of mine. Against B117, everything is fine. So just at the moment, no need to worry. Against B351, we've got reasonable data, and it may be true that AstraZeneca is not quite as good against B351 as the mRNA vaccines are. If that turns out to be true, so two ifs. If that turns out to be true, and if we start to see more B351, I think probably the right response, and what we'll do is we'll switch people's second doses from AstraZeneca to an mRNA vaccine. Okay, so we're now seriously talking, and totally reasonably, about mixing vaccines. We're not going to make a decision until we see what happens, right? I think so many things can change in vaccine supply and what we know about mixed doses and all those things. There's just no point in making a decision that we don't have to make until 4 to 6 weeks from now. So we will make that decision about mixing doses, and I think that's probably where we're going. But we want to be making it when we have as much data as we can get in order to support the right decision. And at the B351 at the moment does not seem to be causing major issues. If we're seeing something coming up behind B117, it looks like it's going to be the Brazilian variant P1. And we just don't have enough data on P1 and to really make an intelligent assessment about whether there's going to be reduced immunogenicity or not. It doesn't appear to be dramatic, but that doesn't mean that there's not going to be some reduced effect.
Thank you, Allison. So I'm just going to, you've answered so many questions and there've been so many grateful comments in the chat. I just wanted to touch on a few things. People have asked, can we compile also many of the answers that you provided in written form or that resources people put in the chat? Absolutely, we're going to be compiling a Q&A and including some of the resources from the chat as well. And so stay tuned for that. Just want to, build on the comments related to pregnancy. So hot off the press, and I think Alan Grill just put this into the chat as well, that pregnancy is included now in the highest risk category. So they are allowed to book, and I believe Alan actually put the information from the provincial booking site. So that's, I think, very new. So that's something for us to all get ready in terms of telling our pregnant patients that they are now eligible to book, which is wonderful news, and thanks to the advocacy of many. I think there was an interesting, just comment about risk and how do you communicate that? And I think Dr. Vincent Lam mentioned, he often compares that risk of AstraZeneca with the VIIT and AstraZeneca to the annual risk of mortality from a motor vehicle collision, which he says is 5.2 in 100,000 for Canadians in 2018. So I thought that was a nice comparison. And then lastly, I think Ross Kirkconnell from Guelph said, even though the vaccine supply is running out, but we're still getting prepared as family doctors, and that's certainly something that we can do. So Brian, maybe you could bring up the last slide as I just finish this. So he was saying that in they are doing searches in their EMR and identifying people in high-risk neighborhoods, people who are going to be ready to be eligible for the vaccine so that they can contact them as soon as they have vaccines. So lots that I know all of you are doing. It's been great to see this enthusiasm and engagement. And I personally draw inspiration from all of you and the energy that you bring to these sessions. I want to thank Dr. Rosemarie Lall and Dr. Allison McGeer for their contributions today. I think we all learned a lot from a practical perspective and then from a theoretical perspective in terms of what it is that we can do in our part delivering vaccines. As usual, the session is, the recording of the session will be made available, and anyone who didn't hear it is eligible for Main Pro credits afterwards. Those of you who attended today will get your Main Pro in the mail, by email. And we are doing these sessions now bi-weekly, and we'll be sending out an evaluation, and we really do appreciate you letting us know what you want to have on our next session. So we take your input very seriously. So thank you so much to everyone for all of the work that you're doing in this difficult time. Stay safe, and as Liz said, stay hopeful because there is hope in the work that we're doing and the trends we are seeing.